Okay.
Tom Baird, attorney, Foster, Jones of Foster, municipal attorney. Tom, you with us?
Here.
Okay. Hi, Tom. I saw Turner Benoit was also here. Turner, we saw you on Saturday at the Fern House event.
It's good to see you there. Hi, everyone.
Ann, is Ann on? I know that we have
I'm here.
Oh, there
I
you
am
are,
on.
Ann. Great.
Good afternoon.
Good afternoon. And I saw Ariana Ciancio, Delray Beach Police Department.
Yep, I'm here.
Okay, got some encouraging news from Delray as well. Dr. Anita Kakovas, Executive Director for Community Recovery, the Hub.
Yes, I'm here.
Okay, hi, Anita.
Hi.
Darcy Davis, I saw Darcy, you were on from Healthcare District.
Darcy's actually on vacation.
Oh, I'm sorry, no. Dr. Andrick, you're here. Okay.
And Dr.
We
Phillips,
already
I think
established that.
she's here. So we are well represented. Thank you for having us.
Okay, Uta Gaziak from Florida Behavioral Health Association. Uta?
Hi, Al. I'm
Hey, there
here.
you are. Michael McKeo from Oxford House. Michael, you with us?
I'm here, Al.
Great, thank you. John Hewlick, Palm Beach County Services, Community Services Department. John?
I think he's on vacation now.
Oh, okay, thanks, Susan. Tama Cudman, attorney. Tama, this will be your first meeting. Are you on? Okay, I think she'll be tuning in. Department of Children and Family. I don't know if Kelly, are you on or somebody from the department on? Nobody from DCF today? Okay. Jeff Lynn, attorney.
I'm sorry, I'm here.
Oh.
I couldn't get off mute.
Thank you. Jeff Lynn, attorney, expert in zoning issues. Jeff, I saw you on. Are you on? Did you leave?
He was on. He was on.
Okay, my bad.
Impossible that he's on mute.
I think there's too much familiarity in this group. Okay, but yeah, Jeff was on earlier. He may have just walked away. Nancy McConnell, CEO, Rebel Recovery. Nancy, are you with us? Or anybody from Rebel Recovery? We will be either in January or in March. Be hearing from Judge Haffel with the drug court. I had the pleasure, and so did with Alexia Cox, our new state attorney, coming in to go to the drug court graduation, and there were 11 graduates, which is the most I've ever seen in 30 years from drug court. So it's phenomenal. And my understanding is they've had close to 90 graduates in the last 18 months with no recidivists, with one recidivist. That's also phenomenal. Okay, Neil McGarry, FCB, Florida Certification Board. Neil? Okay, I saw Dr. Robert Moran, Medical Director, Family Center for Recovery. Dr. Moran, there you are.
Hiya.
Dr. Rachel Needle, I saw you as well, Rachel, licensed psychologist.
Hi.
Hi, there you are. Houston Park, Florida Department of Health. Houston, you with us? Okay, Terrell Pyburn, Coconut Creek City Attorney.
Hello.
Hi, Terrell. Susan Ramsey, also I saw you on. Susan Ramsey with Counsel for FAR and also an attorney at law, fighting the good fight. Micah Robbins, no, sorry. Michael Schlossman for Florida Association of Recovery Residences.
I'm here. Thanks, Al.
Hey, Michael. Terry Shapiro, I'm checking in.
I am here.
Walking.
Thank you. Yeah.
Terry, you're a guy who walks the walk and talks the talk, okay?
Thanks, Al. Great job Saturday. Thank you very much for
Thank
doing
you.
that and being there.
Nikki Soda, Nikki, you with us? Okay, Dr. John Semenides, Florida FSAM, Florida Society of Addiction Medicine. Believe he's either current president or outgoing. Dr. Semenides, are you with us? Okay. Alton Taylor from Drug Abuse Foundation, DAF. You with us, Alton?
Here, Al.
Hey, Alton. Jan Toman, Project Opioid, South Florida. Jan, you with us? Okay, Dr. Lori Vinacore, Alliance of Delray Residential Associations. Dr. Vinacore? All right. I saw Commissioner Weiss. Commissioner Weiss, you with us?
I am here.
All right, great. Thanks for joining. I did receive a message from Richard Worms from the AG's office. He could not make this meeting, sends his regrets. He's got a conflict. And lastly, Eric Urlano, Integrity Billing. Eric? Okay, let's get started with the numbers. Put on some slides here and just let you know how we're doing on some of the areas in Palm Beach County. To begin with, I guess we're going last first. Okay, let's go up to the top slide, please.
This one you didn't. Oh, but it was on the phone.
Okay, let's go to that one. All right. This is really good news. We work with the Palm Beach County Medical Examiners. Our numbers are the newest numbers there are for Palm Beach County. The state lags behind by as much as a year on their numbers, but we've got the 2023 years, and now we have the 2024 years. This says 2023. It's 2024 through November 12th, 24. Let me back up. The top grouping are the numbers for this time period in 23. So that is correct. So there would be no pending cases because all cases have been closed for quite a while. Total drug overdoses were 476. Total opioid overdoses were 373. 78% of the total of OD cases were opioid, which is a little low, but that's kind of how it's been in the interim reporting. Total fentanyl, that's usually around 90% to 93%. And in 2023, up to November 12th, there were 345, which is 93%. It was a 6% decline. When we get to the next slide, you'll see that we've been going down steadily for 3 years. This year, the latest numbers we have as of November 12th, and keep in mind there's 157 cases pending because they're waiting for reports to come in from toxicologists, et cetera. But they only report 17 possible drug overdoses. I think that's wrong, but even if it's wrong, we're doing really well, a lot better than last year. But so far this year, the total overdose cases are 304, which would project, if we use the 157 cases, it would project to a maximum number of drug overdoses to 461, which is still below last year. The total opioid overdose deaths is 202 so far this year, which is 66% of the total OD cases. Maximum would be projected at 66% with adding an additional 157, which I can almost guarantee you they're not all drug overdoses. And probably less than half, but projected max would be 304, which is about an 18% decrease from last year, which is phenomenal. We could be, if we're closer to the 17, we could be as much as 40% below last year. We haven't been below 400 since 2016. We haven't been below 300 since I think 14 or 15. So we really are going in the right direction. This is very promising. And hopefully we continue through the end of the year. We'll know the final numbers by around April, May of this year with all pending cases closed. Anyway, any questions on this slide? We'll go to the next one. I wanted to put this up there because we've got numbers from the state up through 2022. And that year we had 431. Last year, I believe it's around 404. There was a significant decline last year. Well, significant meaning around 6%. But we're going to get those numbers the end of November or December sometime. So we'll know what the 23 numbers are going to be. But if you look at this chart, Palm Beach County in 2017 was 15% of all opioid deaths statewide. You can see in 2022, we're 7%, so we've gone down more than 50% from that first deadly year. That was the worst year, 647. And we had a couple of years where we went up and the state went up as well. But we've been pretty much steadily declining since then. But I just wanted everybody to put in context the last 8 years. This is some good news, and this is why I'm very encouraged with regard to countywide. And I'll ask Ariana Ciancio from Delray Beach to explain these numbers. These are the Delray numbers, which are a 5-year comparison of opioid ODs and opioid deaths in Delray Beach.
So as we all know, I've been tracking the numbers since I started back in about 2018, but Al had asked me to capture just the last 5 years. And what I did is I took off November and December of every year so we could see exactly where we were at this point of time every single year. And as you can see, our numbers are declining as we are going through our years, which is the trend for we have seen. The red obviously is the 1 month per year that we saw the most in that category. Yeah, but you can really see where our numbers have really been declining. This year is a huge decline, but I didn't break down the numbers of, like, I'm still waiting on some medical examiner reports, but we're like at a 90% rate of fentanyl. And I think we've had 1 death so far this year that didn't have fentanyl in it. Yeah, but our numbers are still looking good.
Yeah, I know when the ASU opened up, already at that point, I believe that was 2018, we were seeing hardly any heroin in the drug supply. It was all synthetics, mostly fentanyl. And that's why fentanyl, when you look at opioids, it's 90%, it's riding 90% to 93% of all opioid deaths. So that's not unusual that the opioid deaths would be fentanyl related. And I will say the number 16, which is 2024 so far through October, is probably going to go up some because, as you said, Ariana, you're waiting for some medical examiner reports to come back.
Yes.
But if it's stuck at 16, that's a 40% decrease from the year before. So very encouraging.
And I could just see right now from this month, we've had 1 death this month, so that I have documented. So we're at 17 at this point.
Okay. Okay, yeah, but I'm just talking about the 16
Yes.
for the first 10 months of the year.
No, I know.
Yeah. Okay. Any questions about Delray Beach's numbers? Okay, let's move on to the next. We keep a tally ever since 2017, and a shout out to Fire Rescue. They've been really good at keeping their numbers. But if you notice, other than a couple of aberrations early on, well, not early on, but specifically in 1 year, 2020, we've been going down steadily since 2017. We're down to 795, and this is real. There aren't going to be any more add-ons to this. So as of, and it says September 1st, I'm sorry, this is November 1st. I need to edit that. But January 1st to November 1st, we're down from last year 26%, but we've got a 66% reduction in transports since 2017. It's due to a lot of things. To the extent that the task force has helped, we have brought silos together so that we're more effective in getting people into treatment. Narcan is a big deal. The sheriff began carrying it. It's all over. So that's also, I'm sure, contributed in a large way to the net change. But we really are going in the right direction here in Palm Beach County. So very encouraging numbers to keep on going down. If we see a 40% decrease, it will be amazing in the opioid overdose deaths in Palm Beach County. Right now, it looks like 18% at least. Okay, now let's move on to the FAR update on the numbers. Let's get that up on the screen. And I believe, Michael, you're going to be explaining these to us.
Yes. Should I share my screen or are you going to put it up there?
We're putting it up.
Okay. Hey, everybody. So here are our numbers as of November 2024. We have, I'm going to focus on the beds. We're at about 9534 beds. We're going to, as we get down to, I think, the second or third page, we expect to be over 10,000 very soon and at around 10,500. And that's a lot of that's due to the new legislation and the requirement as of July 2025 that day night with community housing be FAR certified. And so Broward County has about 29% of all statewide beds. Palm Beach County has about 37.6% of all beds. And breaking down the numbers in Palm Beach County, we have 99 certified providers at about 3586 beds. 3 of those programs are level 1. 60 of that, if you could just go back up for a second. Thanks. About 60 of those programs, 1,775 beds are level 2. There's 6 programs with 120 beds, which are level 3. And then level 4, we have about 45 programs, which is about 1,647 beds. Thank you. So if you want to go down a little bit. So we're doing a lot of work right now. You may have heard that FAR received a state appropriation to go do town hall meetings across the state. And we did our first one up in the Treasure Coast last week, which was really well attended. So these are the Florida counties where we do have currently certified beds. And we're working a lot right now on Treasure Coast, Sun Coast, where we actually just opened up a regional office there with a coordinator to be responsible for that. And also down in Miami-Dade. And we're going to be opening up regional offices across the state. And so we have 4 more that will be opening within the next year. And the idea is to have an assessor who's actually in the community, who can answer questions, who can do interviews and handle grievances and incident reports, but also to work on on still the problem of uncertified recovery residences across the state. So if we can go up.
Up or down?
I'm sorry, down. My down. So here's the trend. The trend has been continuing since July 2017 when we started keeping records. And so as we saw, we're at about 9534. It may be a little bit higher than that. I think there's some discrepancy in our numbers. It might be up around 9,600. But as I said, we expect to be over 10,000 beds very soon. So if we keep going down. So here are our overdose numbers, and this is January through November. And remember, these are self-reported. So we don't know about something unless our providers send us an incident report, and we've recently tightened up that incident reporting. It used to be within 72 hours, and now it's within 24 hours. And so we're doing a lot of education and outreach on a lot of issues, but also on incident reporting. And an incident report for us is any time that a EMS is called to the property, so not necessarily for an overdose. So January to November, we had about 30, 27 male, 3 female. We had 7 deaths, and so that's about a 23.3% fatality rate. And you can see below you broken up by city. So I think Ariana said there was 1 this month in Delray, and it looks like according to our records, there were 5 from January to November. So that about matches up. So if we want to keep going down. And here are the overdose numbers by demographics. And you can see that, and also by level of care. And of course, opiates, especially fentanyl, continues to lead with about 25. And let's see, I think that's about it on our report.
Okay.
Any questions or anything else you want us to add to that in the future, just let me know.
Michael, before we open it up to any questions from the group, having accurate data is very important. And are you comfortable with your process to be able to capture the number, especially the number of overdoses and overdose deaths on the 9,500 beds plus that are in Florida right now?
So my confidence is not as high as it would be because they're self-reported. And so what happens once in a while is we will find out about a death and we'll look to see if there was an incident report, which if we're looking, we know there wasn't. And we'll call the provider and remind them of FAR's policy and procedure on this. So we are working on ways to improve that. And I agree with you that accurate data is super important.
Because it's amazing with 9,500 beds through the first 10 months of, or 11 months actually, almost, of 2024, there's only been 30 overdoses and 7 deaths. I mean,
It's
that's
vastly
outstanding.
underreported, right? As is every other incident that should be filed. So we're working on a lot of compliance issues when it comes to that, which is new for FAR because now we have the expanded people power to be able to follow up on these and do that. And there's been a lot of changes. So for instance, every single time there's a death now, we actually get the ME report and the police report if we need it also and investigate to make sure that the facts match up. And in some cases they do, and in some cases we're doing further investigation on that.
Okay. I saw that Terry Shapiro had his hand up. Terry, did you have a question or a comment?
No, I was going to say exactly what Michael said. I'm sure it's just, he can only report what when people write the incident report and call themselves in when that happens. And I'm sure there's a lot of underreporting or omitting information, not always intentionally, but sometimes intentionally. But great answer, Michael. Thank you.
Yeah, absolutely, Terry. I agree.
All right, seeing no other hands, I do want to just put up an article that's in your packet that you received. It's a study that was done in the Journal of Substance Use and Addiction Treatment. And it's kind of germane to the MAT issue. So I'll start by saying I believe in January, we're going to have, no, this is the article. In January, we're going to have a meeting dedicated largely to the rollout of the new statute that takes effect in July, that you can't refuse somebody solely for the purpose of the fact that they're on a MAT validly prescribed MAT regimen. Buprenorphine is the one that we have the most problem with, and it's the item number 7. No, you missed it. Yeah, there it is. Okay. All right. The wonders of modern technology. So let me move this over. So there was a study done in Dade County. I think it was out of Dade County. But I just want to mention that as of 2022, because that was it was July 22 to December 22 was when
it was Dade.
collected.
It was Dade. Correct. It was Dade. You're right.
Okay. So 100 certified recovery residences were part of a study as far as allowing MAT, and 16% of the 100 permitted all MAT, including buprenorphine, without conditions. 31% had conditional acceptance, and that would be they would require titration or a dosage amount that they'd have a cap on a level that it couldn't exceed, something like that. And then over half of them, 53% prohibited MAT. So I know, Michael, that's one of the things that you are going to go across the state, because again, the law has changed, and people need to realize that just like somebody who has diabetes and has to take diabetes medicine, if it's a properly prescribed MAT prescription, that they can't be denied solely for that purpose. Now, pragmatically, we can talk about level 1 and 2 housing, where somebody who's just suffered an overdose and is in intensive treatment may not be appropriate for an Oxford House, for example, or a level 2. But there are other reasons for that. It's more long-term. But for most of the recovery residences, level 3 and level 4 in particular, I believe those numbers probably already have changed significantly in the last year and a half, 2 years. Michael, you wanted to comment on that?
Yeah, and thanks for bringing this up, Al, because this is the basis of what we're going around the state talking about. So we have 6 regional town halls. We're calling them brunch and learns, all set up between now and May. We also instituted quarterly Zooms with all of our providers, which we just finished our first round. We're doing the meeting with you all in January, and we just scheduled an MAT best practices seminar down at Fellowship Recovery down in Broward. And so this is the thrust of what we're discussing is the current legislation, what it means, what it doesn't mean, best practices, our experience with this, and also our policies and procedures. And we've created templates for our providers to make implementation of this super easy. So if anyone needs any help on this or has any ideas, please feel free to contact me.
Okay, so we'll look forward to January when we'll get a in-depth discussion. And I see Houston Park. Welcome, Houston. You've got your hand up. Comments?
Yes, I do. I just got a question for Farr. Because of his reports of the fatalities that have occurred in a Farr residence, is there literature or information that's provided to people that come into these Farr residents that could or would put them directly in contact with the CORE program, so that if they do need MAT services or any of the other services covered by CORE, that it would be a direct line for them?
Not directly about CORE, as far as I know, Houston. But one of the things that we're doing is making sure in our best practices that there are providers or opportunities for MAT clients, especially if they don't have insurance or don't have a doctor. And so I just made myself a note to make sure that we put that in there.
That would be great, because right now DCF is rolling out another 17 counties, and that should put us at about 87% of the counties across the state that have some type of CORE MAT service. And as far as Farr goes, having clients come in and have immediate education and availability to become part of CORE, I think would help reduce the number of fatalities or overdoses that we're seeing in at least the Farr residents.
For sure. And for instance, one of the things we're also doing is, although 100% of them report to us that they have naloxone, we're still doing naloxone training and offering to give it to them for free if they don't have it. So there's a variety of things that are going on which are wraparound to the MAT discussion.
Oh, that's excellent. Thank you.
Yeah, thank you.
Seeing no other hands or comments, I do want to take this opportunity. I'm very happy to introduce Alexia Cox to everybody on the State Attorney Addiction Recovery Task Force, and all those people that are joining us that are not on the task force itself. So Alexia, you're on. Would you like to say a few words?
Can you hear me?
Yes.
Okay, great. Thank you, Al. Hi, everyone. I don't want to take up too much time, but I appreciate the opportunity to just say hello and introduce myself. I see a lot of familiar faces, some old and new friends on this Zoom, so I'll say hello to you, but a lot of new faces and people who may not know me, and I want to make sure that I pop in as much as I can to really learn more about the work that you're doing. I commend you for your efforts, because I can tell you that over the past 18 months of campaigning, I heard a lot of concerns about crime and public safety, but one of the bright spots through the community has been hearing about the work of this task force and the way that we have been so proactive in addressing substance use disorder the treatment industry and really making a difference in Palm Beach County. And I'm really proud to learn more and be a part of that. And I look forward to doing everything that I can to extend this work moving forward. So I just want to say thank you all for your efforts. I thank you for that fist bump, Terry. And I just wanted to take this opportunity to just say thank you. And I look forward to learning more and being involved, actively involved in the work that you're doing. So thank you, Al, and everyone here. And I hope to hopefully see you all in person soon. Thank you.
Thanks, Alexia.
Thanks, boss.
Okay, we're up to Oxford House, and then we're going to be doing a brief presentation by the Healthcare District. Michael, you with us? You want to do the Oxford House?
Yes, absolutely.
Report?
Thank you all. Yeah, so currently throughout the state, we're at 228 houses with over 2,000 beds now. We have 136 men's houses, 40 women's houses, 47 women and children's houses, and 5 men and children's houses in various cities all throughout the state of Florida. We've had one overdose, non-fatal overdose since the last meeting. That was in Clay County. That's just south of Jacksonville, Orange Park area. Yeah, so we hosted our World Convention in Orlando back in October. We were very honored to have Attorney Ehrenberg speak at it, and it was very impactful. I believe that it was a really cool insight for a lot of our membership and staff in other states to really see what this task force is doing throughout the state of Florida and in Palm Beach County. And so I think that it was well received, and there's even a couple well-timed jokes that really made the crowd laugh. So it was good. So looking ahead, we're wanting to continue to expand throughout the state, providing houses in the much needed higher populated areas, but also focusing on more rural communities. There's a lot of inland areas throughout the state that are very underserved with all kind of different resources, including housing. So we really are wanting to tap into those as best that we can. It's difficult though. There's issues as far as public transportation, employment opportunities, anonymous meetings and other recovery type meetings. And so we have to navigate that. We've had success in other states with kind of comparable situations. And so we're going to work with some of those staff in other states and to figure out ways to kind of get through some of those issues. And then we've had success in current cities that we're in Florida that do not have any public transportation. And so we've been able to overcome that hurdle. So we're just going to continue to work with different area resources to figure out how we can best serve those communities. And we're continuing to do trainings all across the state, just focused on the Oxford House model, making sure that our membership, the new membership, the long-term membership are comfortable in our model and are able to operate it successfully. We do that continuously on a house level, chapter level, state level, regional level, all kind of different trainings that we do. We do incorporate in a lot of that fun and unity, and we want people to really appreciate being a member of Oxford House. And so we really try to incorporate that in all that we do, so that it's not all just sitting in a classroom all day, but it's really membership, having the opportunity to fellowship and become a part of this and really appreciate it. We have our upcoming convention in May. It's Mother's Day weekend. It's going to be in Orlando. And then just a kind of hurricane update. We've lost 3 houses temporarily due to the hurricane. We had 2 houses that flooded, and then one that had a tree drop on it from a tornado. And so all of those are being fixed up and ready to go, and should be ready to go in the next few weeks. And so that's that.
Thanks
we do have a new website too, so check that out.
Okay. Thanks for the update, Michael. Anybody have any comments or questions? I did want to ask you, well, actually, for those who might be on this Zoom meeting who don't know, there are 4 levels of recovery residences, and Oxford House would be your classic level 1, which is a longer term residency, people who are mostly post-treatment that choose to live together in a sober environment. And so it would stand to reason that there would be fewer overdoses in an Oxford House than in say, a level 3 or level 4 intensive outpatient treatment connected recovery residence. But my question, Michael, is, and I asked the same question about with FAR to Michael Schlossman. Do you have any kind of fail-safe with reporting? I mean, is it self-reporting? Do you check? Do you cross-check to make sure that there's not a problem, say, coming from 1 or 2 houses?
Yeah, I mean, so our staff in all areas will do an incident report themselves in concert with the houses that experience that. In any incident where any kind of emergency services were to come to the house, we'll do an incident report. And so, I mean, it's really, it's on the outreach staff in that area to make sure that that's being done. But we do that, and they're making sure that they're communicating with the houses and the members in the houses are communicating with them. And I don't believe that we've had an instance where any house has hidden the fact that somebody has had an overdose.
Okay.
I truly feel like that we've done a tremendous job in making sure we've got all of them.
That's great to hear. Okay, without any further questions or comments, we can move on. Oh, by the way, Michael, just so you can remind us, when did you open up the first Oxford House here in Florida after the agreement with the state on backing the first few?
Yeah, March of 2019, we opened the first house in Tallahassee, and just been going since then. So
yeah, 2,000 beds in 5 years, unbelievable.
yeah,
good job. We now have in Florida over, we're closing in on 12,000. Once we get over the 10,000 mark with FAR, we'll have 12,000 recovery beds in Florida that are certified or Oxford House. There's no state in the United States that can boast that number. Great job, Michael. Great job, both Michaels. Anyhow, let's move on to our first agenda item presentation from the Healthcare District. Dr. Courtney Phillips, you're going to share your screen with us, Courtney?
Yeah, can you see it?
Yep.
Okay. Hi, everybody. It's an honor and pleasure to be here as always as with the Healthcare District. I am an addiction psychiatrist and our Vice President of Behavioral Health, and I'm excited today to be amongst these giants in the room, I'm going to call it, because there's so much great work going on. It's great to hear what everybody's doing, and we're seeing it on the ground. Today, a lot of you guys have heard us speak about the past or what we're currently doing. This is about the future. This is about where we're headed. And it's, over the last 7 years on this task force alone, we've seen a lot of great things happen and been able to address a lot of things as a group. But we still see that there are struggles and there are inconsistencies in the system of care, not just for substance use, but also for mental health. So that's what I want to focus on today and tell you what the Healthcare District is planning on doing to start to address some of that, okay? Amongst many of you doing these great things in the community. All right. So really quickly, just to kind of give that overview, I don't have to preach to this audience too much, but the Florida Hospital Association sponsored a legislative blueprint called Behavioral Health. It was published in October of 2024, talking about Florida's behavioral health continuum of care. And just at the Florida level, 3 million adults have a mental health condition in Florida. 29% of them were cited to not be able to access any mental health care. 62% of kids who need something did not receive treatment for mental health or psychiatric care. And this all includes substance use. So mental health is a broader, description of substance use being a chapter of, and as many of us know, part of many other problems as well. And it also showed, this report also showed a financial sustainability problem. For example, inpatient beds, right, which is the older traditional model, are $2,000 per day in the state of Florida on average. And they cited actually in that study that a little over $100,000 per patient on an inpatient stay. So it's a very expensive, difficult to sustain solution. And even when they come out of those expensive options, they do need continuous care. And as in the country, we rank 49th for mental care access as a state. Now, and so I just want to say what's going on in Palm Beach County is also happening nationally and statewide. This isn't a special problem for us. But just to dive a little bit deeper, on your right, this same report that I'm citing talked about this is one example. So there's many, many examples, but I pointed to one in Palm Beach County, which is, you see, according to ACA, we are Region 9, which I put around in red. We're the top 3 utilizers of kids going to the highest level of service, which is a Baker Act receiving facility. And this is one little subset group. What this means to me is kids in Palm Beach County really are accessing the highest level, partially because we're struggling a little bit to get them into or know about upstream services, which are lower levels of care. We also, to me, this also means there isn't enough access to care for kids in this particular example. But there's many, many other examples across different illnesses. Substance use is one of them, but this is particularly towards kids. And if you look at what I'm seeing, we all see that there's current issues that are coming up still. Over the last 7 years, many different things have come up that have affected our system of care. But most recently, JFK North announced that they're not going to have inpatient beds or admissions for kids 12 and under. They'll receive them, but they have to be sent out of county if they need a Baker Act receiving facility. And that's a most recent change. They have their reasons, and they're saying they're having less capacity, but still, it's now a new growing crisis for us in Palm Beach County. Another example is I just read in the Miami Herald yesterday that WellPath, which supplies a lot of, and this was discussed at Criminal Justice Task Force, supplies a lot of mental health care in the jails, is going bankrupt. Obviously, we hope it just leads to a future of uncertainty. WellPath is the agency that oversees neurobehavioral. I hope they restructure and they still are in existence. But again, a lot of uncertainty in the system and gaps. So that's what I wanted to point out. So we need an integrated crisis center that will match clinical services with patient acuity level, match community services to patient social care needs. So when I say that, I mean on-site physical collaboration on-site with criminal justice systems, both on the police law enforcement side as well as the specialty court side. Recovery integration with recovery-oriented systems of care, lifelong care, and social determinants of health like homeless groups, food banks, etc. And we also need support and collaboration with current existing programs to enhance the system. So we have a lot of really great things going on in Palm Beach County with different groups, and we all should be proud of that. But this would support and collaborate that even further to add more to that system, which is what we need with such a big community. And it also offers an alternative to jail and emergency rooms, but also works together with criminal justice and private hospitals in one physical location to sort of foster one PBC team, right? So we're happy to have our private hospitals that have lots of inpatient beds, but we need to work together with them. We also have South County, which is a wonderful group, but we need to work together with them to help them sustain their programs. Like we saw with JFK, who's losing 12 and under, we don't want that to keep happening with different subgroups, right? That'll squeeze the system even further. And these are, like I said, just a few recent examples. So I'm going to pause for a second to talk about our solution. And while I'm doing that, Al, I have an interactive version of this. I'm going to stop sharing for a sec to pull it up. Give me a second. Okay, so I think it's right here. Can you all see this bigger map? Yes?
Yes, can't read it though.
Okay. Okay, it's too small. Okay, well, let me just talk for a second and then we'll get into it. But, and these can be sent out to you in a PDF form, but this is a little bit more interactive. And this is a very early iteration of what we're trying to do at Healthcare District with partnerships, is to build a crisis center for mental health and substance use. It's a place for everyone to go, which is what, and with 2024 guidelines in mind. which there are national best practices for places like this. It's to support our private hospitals, to create a larger ecosystem, support our partners with South County, support our Saartf family, and take the load off so that we can have this, this for generations to come, and sort of have a public-private sharing of things. We're hoping that this facility will have Baker Act receiving facility accreditation, addiction receiving facility accreditation, certified community behavioral health, FQHC, which we currently are, federally qualified health center, and crisis stabilization unit. It has the 24/7 component, which you see here is police drop-off in a Sallyport or EMS drop-off all the time. Best practices are 10 minutes or less that would happen. And it also has chairs, which I'll talk about, for up to 24 hours, and then a small crisis stabilization unit. The number of beds in that unit, as you see for kids and adults, are based on a feasibility study we got last year, but we're going to readdress that as we see the newer capacities for or what's happening right now in the county with current bed state to see if we need to change that number. But you can see that at the Sallyport, officers would be able to, in 10 minutes or less, be in and out. Same with EMS, because we would take those from patients, and this is the best practice. So I don't know if you can see that image popping up.
Yeah.
Of a Sallyport. You can see that a patient would have a dignified, we could keep all of their stuff. We'd have sort of like a locker system where they could bring 3 bags if that's what they bring, whatever they need, and they'd be able to have, delousing, showering, clothing, things like that. Interestingly, if anyone who works in the field, you do have patients who say, I'm not going in there without my dog being taken care of. There'd even be a kennel, so that if the patient needs to be inside of a facility for a bit, we could take care of that pet if that's what it's going to take. But they'd be quickly triaged in this system to decide what acuity level this patient is at and what is the best place for them. As you can see, the outpatient clinic is actually on site. So if the acuity level from the walk-in side is that they need to be an outpatient, it's right there. We can start the services right there. If the acuity level is higher than that, then there would be locked areas. Like I said, if they came in as a Baker Act or something like that, this is our inpatient side. This is what makes this up to 2024 standards. It's called an observation area where someone can be there for up to 23 hours. And I think this is what makes it very unique. So there's never going to be enough beds. We need them, we have to use them, but we have to use them very efficiently. This would be a humane setting with a lot of design in place to help make the patient feel warm, calm, all of those things, as well as part of a community, not an isolative kind of institutional look. But the care would occur here. So patient would be in a chair like this. This is another facility that we visited. But they would receive medication management. They would receive therapy for crisis. We were planning in this area to have even a group room to talk about whatever crisis is going on and how to manage those coping skills for that, as well as an area where community agencies could enter in if housing, if food, if things like that are a big part of the patient's presentation, they could get those services addressed right there. So this is, obviously we're taking the lead on this, but this is a facility for Palm Beach County. And if that person can be stabilized within 23 hours with a plan and plugged into lower level services, not fall through the crack, get connected to peers, get connected to those social services, all right there, then that is what it's all about. We talked about law enforcement and obviously if they need admission, right, there would be a small adult and pediatric crisis stabilization unit that we may adjust the numbers based on how many beds are left in Palm Beach County after the WellPath restructuring. But you also see here that the hope is, right, this is not an architectural design and it still requires some thought, but this is what we're hoping, and many places across the country have this, is mental health court. There's Judge Leifman, has an on-site courtroom for specialty courts, even homeless court is a discussion. I know you're talking about drug court, but that people in the system could also access, legal services right here. And that could be part of their treatment plan. And then you see room for case management or recovery-oriented system of care. So this is not the actual design and the way the layout would go, but this is a bigger picture of what we're planning for the county. And I think the other important piece is that they get long-term care in the clinic, right? With a pharmacy, we're planning on a long-acting injectable clinic and even possibly a TMS suite. So keeping transmagnetic stimulation for outpatients as well as anyone on the inpatient side who could utilize that and staying up to best practice. So this is what we wanted to present today as a concept. This is something that we're very interested in providing to help assist all of the teams here in building more for the community, to partner with JFK, to partner with Delray Pavilion, to partner with South County in this process so that we ultimately have more resources for our community. And that's really what I wanted to share today. I just wanted to pause for a second, see if Dr. Andrick had anything additional to add.
Yes, hi, good afternoon, everyone. Thank you, Dr. Phillips. It's a very complex topic to really explain in a few minutes. And I know I presented concept of crisis now model in the past. It's going to take us a few years before we grasp everything. But I think what we have to keep in mind that this is part of nationwide ongoing transformation of psychiatric care. So this is beyond ASU, and we saw the numbers, right? I think the all interventions that you implemented, including big regulatory agencies to control how much controlled substances we prescribe, are collectively result in drop of the numbers. But underlying cause of the underlying cause of all substance use disorders issues is not only uncontrolled prescribing controlled substances, but also mental health and untreated mental health, what results in people self-medicating themselves. So we have to really address mental health crisis from that aspect. What is the national recommendation? How we do that? And they are talking nationwide about that different approach in psychiatric care, that we need to increase system redesign that include innovative crisis management. And this is innovative crisis management, but it's evidence-based. Those are the SAMHSA guidelines recommendation, how you transform crisis care in your community. So those beds, 23 hours observation beds, are the kind of heart and soul of facilities like this. This is where you really provide very comprehensive wraparound of services, from psychiatric care to nursing care to primary care to licensed social workers assessments, psychosocial assessments, to connecting them to the social determinants of health, all with intention that you don't keep them in the beds, that you diffuse the crisis, put them in outpatient ongoing treatment for lifelong treatment, and kind of prevent future crises. So, but if they need the crisis, they would have a place to go. So again, a very complex topic, try to really pack in a short period of time, but that's what we are focusing now on.
Thank you, Dr. Andrick. I see we have a couple of hands raised. Terry Shapiro.
So I love the project, and have been over there with Judge Leifman several times over the years and drive by his facility here in Miami on a regular basis. And I still don't understand why it's not open. So how is this project going to be funded? Because I think that seems to be the sticking point for his place, because it's spectacular and can really help so many people. And I was really excited to hear you, Dr. Phillips, bring TMS into the equation, because that's something we've been talking to Judge Leifman about as well.
So I can address that question. So this project, building itself, a facility-based, will be sponsored by the county commissioners. They are voting on $10 million to dedicate to that, but this will be 60,000 square foot facility. Estimated cost is probably going to be around $60 million. So the rest of the money we have, our board is in support of this. Difference between us and Judge Leifman and Miami is that we are having the Health District Board support for mental health initiatives, and us kind of really stepping into this arena on mental health. So that's a good news. There is estimated probably around 40 million ongoing costs for that. And we are working on also ensuring that this is our future business line supported, no different that we support other business lines that address physical health. So we are the local taxation district, and sponsored by big part of our budget structure is the taxpayers, property income taxes. That we are working on improving a lot of other efficiencies to be able to sustain this ongoing cost. So there is a lot of discussion about that. That's kind of big overview that unlike Judge Leifman, it's coming from organization that is a healthcare provider in this community. So this would be another line of business for us.
Yeah, it's fantastic. I didn't hear you say you're going to be washing feet, though.
You mean for the patients?
The way Judge Leifman talks about when everybody
yes.
comes in. That
Well, he has many other features like facial tattoos removal. That's a big one for Judge Leifman.
Right.
I mean, we already explored those options. I'm not saying no to that either. But
Good. Awesome.
But we did have like the courtroom here. We are hearing about homeless court as well. It's not only mental health court, but homeless court. And this facility of this kind can support all of those community needs.
I'm going to, before I hand it over to Rachel Needle, I've seen this over and over again, and we are dealing with scarce resources, even with the opioid dollars. And I know this is separate and aside from that. But it always comes down to the scarcity of funds. And it's my understanding, and correct me if I'm wrong, and I don't want to step out of my zone here, but it was my understanding that the healthcare district was going to fund this up to about 80% of the cost. And that's very important when you're giving a presentation like this, because I can guarantee you there'll be fewer people that are going to be against it if they know that you're putting in the lion's share of the resources and it's not coming from other, from scarce resources going to other places.
That's a great point, Alan. I appreciate you bringing that up, but we're always open to partnerships too. So yes, we are, as Dr. Andrick said, the board is in full support. There are funds identified for the initial cost, but we have to, just to repeat, we have to work on, part of our strategic plan for the clinical side is matched to the financial sustainability plan on the operational side. So we still have to work some of those things out, but on the initial build, you are correct that we're putting a large amount into that from our reserves is the plan.
Thank you. That means a lot. Alton Taylor, you've got your hand up.
Yes.
Sorry, Rachel. I thought you put your hand down. Let me do all.
I did just because you called on me, but I'll go next. No worries.
Okay, Alton, go ahead.
Yes, Dr. Phillips, I noticed that, and maybe you have it somewhere else. Will there be a clinic in this structure that can take care of primary health needs, dental needs, long-term health needs like diabetes and that kind of thing?
Yeah. So we are planning on having integrated primary care for sure. As far as dental, we are discussing that, but we also have a huge system for dental that we can tap into for those patients. So those are part of the discussion, but integrated healthcare is our current business, and that's something very important to us to maintain. So yes.
So those services would be
that all top green
co-located.
section, if I can interject, all the top, quarter of this building, there'll be outpatient services for integration of psychiatric and primary care. And I think it's not emphasized enough. And you can see here in all those dotted lines, if you can bring back Courtney, everything is separation between kids and adults, because those are the national guidelines. So that walk-in clinic that technically serves as urgent care, including the Sally Port and the walk-in clinic and the outpatient clinic and the beds and the chairs, all those dotted lines indicate separation between adults and kids. So that's the complexity of architectural structure of facilities like this. And that's why we have that in mind. That outpatient, they'll probably also have pediatrician embedded in this clinic with pediatric psychiatrists. So those are the national guidelines, Alton. I really appreciate you guys are really making big strides in kind of emphasizing in mental health service lines importance of integration with primary care.
Excellent. And one last question: have you worked on a transportation model that would allow all of the county to benefit from this investment?
So, this is facility. We didn't even touch other prongs of this project. We don't even have location for that yet. We are actively searching. So if you have any idea about locations, please reach out to us. But all that will be addressed on different levels, from pound trend to medical Ubers. I think there is a picture, interesting picture. I don't know, Courtney, if you know where it is. There is our clients, but I think it's up by the outpatient clinic. There is one eye that has like a charging station, patient transportation resources. This is often transportation of our patients in mental health clinic. We know that they come with electric bikes more and more. So like, this was interesting idea from other center of this kind, that they have a charging stations outside for scooters and electric bikes.
Excellent.
Hey,
Well, we certainly look forward to working with you all on this. Like I said before, this is an exciting item to come to Palm Beach County, and we'd love to see that get done.
And Alton, if I can just suggest, there is important section in our case management section, that there is a whole section by the court of community partners. So we anticipate that you all will have your offices here, so if somebody needs to go from 23 hours bed now to detox, or is pregnant and need that bed, that's the care coordination, community care coordination, that we will be very proactively and integratively working together.
Great. Thank you.
Okay, Dr.
My
Neagle.
turn? Okay, thanks. Before I comment, a quick question. So the psychiatric appointment, the individual therapy, that will be on an ongoing basis after crisis?
Yes. Yeah, we're working on building out our general therapy program and psychiatric outpatient services. So the outpatient side, yes, we actually now have individual ongoing therapy for group and individual for our patients.
And I think, Rachel, if you see this, you cannot see that, but we can email that and you can zoom out, or Courtney, you can zoom out. And this here says psychiatric appointments, individual therapy, group therapy, and integrated primary care. That's all on outpatient basis.
And that will be, how will that be structured in terms of pay? Will it be insurance-based private pay? What about people without either?
So it would be insured or uninsured. So right now, currently, our behavioral health outpatient side is 40% managed care, and the rest is uninsured. So we'll take all of anyone who needs those services, but also, Dr. Needle, hopefully in the community side, have a network of people that we can refer to too when there's capacity issues and we need to get them into an insured provider or cash paying provider.
Yeah, absolutely. I mean, I think that's sort of like a concern that I had, is this is amazing, right? But we have such few places for people to go, for ongoing care after, whether it's residential, actual mental health that they need, which we're very limited in here, in the area, people that truly do specialize in that, not say they do it too. And even just people, on outpatient basis, we don't have that becomes one of the biggest issues, even in substance use. But when people get out, is how do they continue to take their medication? How do they continue to do psychotherapy? Because, when you're in a crisis situation, oftentimes the medications you're put on might not be the correct ones for long term. So you need actual assessment and continued evaluation. So, I think there's definitely, that's something to flesh out a little bit more potentially. And I'm happy to talk to you on the side, maybe even make it a teaching place where you can take on interns, and I'm happy to support you in that. I've done a lot of those.
That's a great point, Dr. Needle. Like I said, this is for the community, right? We're taking the lead on this facility, but this is for everyone. And we also see, talking to Palm Beach State College and having those relationships where training teams can actually develop their skills here, because it will help develop this could be essential for developing the workforce in mental health in this area. We're very open to that. And I'm glad you brought that up, because even the the kennel, we thought vet tech school, we should bring them over, and they could. So there's lots of cool ideas. And this is really for the community. We have to have the lifelong care. And I think one of the reasons we're very interested in stepping into this space is because that's our foundation now, is that lifelong care. And that's what we want to build on top of that, so that there's more opportunities all the time, because crises happen all times a day. So thank you.
So, and if I could just add, Rachel, on the bottom of that proposed regulatory designations, you see that CCBHC, it's Community Certified Behavioral Health Centers. So that's your federal funding for uninsured. And we already have FQHC designation. That's why that's why we are able to see in Mongolia everybody regardless of ability to pay. We have federally qualified health centers, we receive federal grants, and then we supplement by local taxpayers' money, right? So that sustainable model is recommended for facilities like this because everybody has the same issues. This is lifelong illness. What's going to happen after 3 months, right? When I discharge them. So, you know, as we speak now, you can refer those patients from your community to Mongolia, like, right? It's outpatient treatment that we see everybody as we speak. So please, if you know anybody, feel free to reach out. And I think many of you know how to do that. So, you know, the problem why mental health, while countries in mental health crisis and why all those private providers are like, you know, coming in and out is because there's no billing for mental health. You know better than anyone, right? So there's, I mean, it's not WellPat's fault, right, that they did business bad. It just, there's no money. They have to pay their people. They have to keep the lights on, right? So that's why sustainable model, community coming together is the only way we see at present time, and governmental entities like us and county and Saartf coming together and building system of care like this.
Awesome. Well, I'll reach out for sure. We're past due on a visit anyway.
You promised.
Okay, Belma, I'm going to expand on what you just said. One of the beauties of having a facility like this is you're not at the mercy of a private entity. I know JFK is still doing good work in terms of at least having staff on board. It's one of the only emergency rooms that has licensed the ability to even prescribe buprenorphine on a regular basis, and they have addiction specialists, you know, trained specialists, peer, and I believe they have peers in there as well. But one of the reasons the ASU, which was the model for the entire state, had difficulty, and I'm going to say this because I know you won't say this, is the fact that you know, they changed their model and they took the beds away. And I'm just going to say it plain, which is not it's not saying, you know, anything against JFK. It's just that they're a for-profit entity. This, as well as places like DAF, are what we can rely on. Something like that is not going to happen. And so that's why a project like this is so important. Now, 2 quick questions. One of the problems with the ASU was buy-in from fire rescue across the county in terms of their time out of service to take somebody to the nearest hospital as opposed to JFK North when we did have those stabilization beds. Have you discussed with fire rescue as to this being a priority for, say, overdoses that are transported? Or is that not your bailiwick? They have to go to a hospital first and then to you, even after stabilization?
No, we want to also, I mean, we want to be able to, the best practice guidelines actually say all psychiatrists actually went to medical school. They should be able to do basic low-level medical care. So that medical clearance thing that you're speaking about needs to be very defined, and there has to be high level for that. It's not a reason if their primary issue is mental health and they have high blood sugars that we shouldn't be able to treat that there. So that's an important piece. But as far as speaking to EMS, we have been speaking to EMS about the bigger picture. I think we're ready to have more detailed conversations with EMS now that we are kind of conceptualizing internally where we're headed. And I think that's a really good suggestion. We have been talking a lot to different sheriff's offices, and in our current pilots, you know, we're really in close communication. So from their standpoint, we have to aim towards a quick 10-minute drop off for EMS and fire rescue. So they're not sitting there, and that is the expectation from best practice so they can get back out into the field. So we have to do that internally. The second thing is I think that the site that we choose physically, we're really, really looking at, you know, ideally as central as possible and possibly central to even east and west, right? So just so that it's more accessible to more people. We learned with the ASU, it being north, there were limitations for the southern counties. So that's something we're thinking about, but thanks, Al.
Okay, and real quick, you know, you look at a floor plan like this, and you know, it could be a 3,000 square foot house. How many square feet do you anticipate this is going to be? Just so we can get
About
a global.
60,000, about
60,000 square
60,000.
feet?
If it's one story, which is what we would love to have it on one story, there's a lot of headaches that come with a two-story building, but you know, if it's two-story, I don't know what it would be on each floor. So it depends on the
gross
site
would
location.
Gross would be about
Yeah.
60,000. Okay, thank you.
Yep.
Alton, you have your hand up one more
Yeah,
time. This would be the last
if I
comment.
could comment on something you said, Al, and that is the payment or the funding structure. I think we all know that in the last 2 weeks, a sea change has happened. And with the federal government having a goal to cut $2 trillion from the budget, that's going to put more stress on state systems. And so I know this is recent, but are you all trying to factor as best as you can that kind of funding phenomenon? Because if a lot of those requirements that are funded by the state, particularly all of your opioid stuff, if that starts shifting back from the federal government to the states, I'm just wondering, have you thought about that and how how you might prepare for that as best as you can?
So, that's a great point, Alton. There is a large shifting landscape with financing. We have a whole team of finance, and Darcy's really involved in sustainability with our operations team. I am part of that, and I can speak on behalf of them that we are aware that the financial strategy for operational continuation is vital to make sure that this is successful. And that means squeezing every dollar out of an insurance company as we can, if they have insurance, if they don't, looking for grants, looking for, like you said, the shifting federal and state dollars that exist. And then at the end of the line, really using those taxation dollars to shore this up so that it can continue for the citizens of our county. But I think we're all trying to watch that closely and continue to monitor that situation.
Thank you.
Okay, thank you. Seeing no further hands, let's thank you very much, Courtney, Belma.
Thank you.
For
Thank
the
you all
presentation.
for letting us speak. Yeah, we
This is
appreciate
very
it.
exciting. Now, let's move on to the legislative part. And this is not going to be as long as it might be. I mentioned earlier, if you just tuned in, there's going to be a special meeting just to deal with legislation. And mostly it'll be dealing with the citing issues in Chapter 419 for community housing for people with disabilities. So this is not the right one. So there should be another 311. This one was in error. There are a couple of recommendations that were made by FAR, and I think we got lost in the shuffle here. Let's see, hang on. 311.5. Here it is. No, that's B. Yeah, 311.5. This is it.
Oh.
Yeah. Oh, good. Glad we have this. Okay, I'm going to hand the microphone over to Michael Schlossman, and let's start with an amendment to 397, 311, subsection D, level 4.
Okay, thanks, Al. I don't see it on my screen yet.
Oh, good. Is it there?
Not that I see.
Can anybody see it?
Oh, yeah. I just see your various documents. Maybe someone needs to just double click on it.
So you don't see a particular item 397, 311,
I don't.
6B. Okay, let's see what's wrong.
Maybe I forget. see it now?
And well, I take it you can't see it still.
No, not yet.
Because I see it. Maybe I have to close this one then? Yes.
All right, we're working on it.
Oh, okay. Okay.
Okay, well, Michael, even without seeing it, it's basically a 3-word ad. So do you have it in front of you that you can look at?
Yeah.
So why don't you
Kind
go
of
ahead and
this by heart.
explain what it is while we're trying to get it up on the
Oh,
screen.
here we go. So
you got it? All right.
the codifications of FAR's levels of support, level 1, 2, 3, and 4, have been incredibly helpful to clear up misunderstandings, miscommunications, and really solidify what it means and what it doesn't mean. We have focused on the area of housing that should be FAR certified under a level 4, but is currently not. And those tend to be level 2s that are associated with a DCF licensed facility, but the licensed facility doesn't have a day-night with community housing license. And there's all sorts of indicia of provider-directed care. And so D was meant to clear that up, and it actually caused a little bit of confusion. And so we're suggesting 2 quick edits to it, which is to take out the words "who are required to," and then add in on line 33, "required to be." And this is to clear up a loophole that providers have used to say, well, our patients aren't required to, but yet if you ask them how many people are in the recovery residence, well, 10. How many of them attend the DCF licensed facility? 10, but that's just a coincidence. So they've been hanging their hats there on this required to, and they're saying that their staff is not requiring them to do this, but yet the evidence shows that there are, and we take these each on a case-by-case basis. The other thing that they're using to claim that they're not a level 4 recovery residence is that they don't provide 24-hour staff. And so according to the strict interpretation of the language, if they don't currently provide 24-hour staffing, then they can't be a level 4. The difficulty is that the intention of the legislation was to require them to have 24-hour staffing, not a litmus test that if they have 24-hour staffing, then they would be a level 4. So we've suggested these 2 very quick changes, which should clear most of that up. So that's what this one's about.
Okay, any comments, any questions? Yes, Jeff Lynn raised his hand. Jeff Lynn.
Yeah, before I forget, I'm going to embarrass him because it's in social media, but I want to congratulate Michael on his engagement to the love of his life. And we will leave it at that. So congratulations to you, Michael. Beat Red right now.
Thank you, Jeff.
Who is doing a beyond amazing, stellar job of running far beyond my wildest dreams and is now engaged to the love of his life. So I want to take a moment and say that. Thank you.
Thank you, Jeff. I will. I'll put the check in the mail. I appreciate that.
Well, that's a worthy hand raise. Anybody else? Okay, let's move on to the next one, 6B. It should be 397, 487. No, that's not it. Hang on, let me see here. 397, 311. Here it is, right there. Okay, perfect. And this is really cool. Michael, I'll let you describe what you want to do.
Yeah. So as probably all of you have heard, FAR now has statewide reach, and we're every place, and we've torn down the silos and the old sort of maybe disagreements that have happened, and we're reaching out to everyone and trying to work together with everyone, and that includes the managing entities. And so one of the things that we've noticed is that in most regions, managing entities require that their vouchers be used in FAR certified homes only, but yet the exception still exists in law as to a licensed provider money that goes directly to the from the managing entity to the recovery residents. And so we've suggested that we remove the managing entity exemption. And we feel so strongly about this because FAR certified homes, not just anecdotally, but statistically, create more opportunity for long-term recovery, decrease exploitation, all the things that we know that FAR certification does. And we feel so strongly about this that we want to take away, we want to put out an offer that we wouldn't charge bed fees if this exemption was taken away, because we don't want someone not to get FAR certified simply because they can't afford the bed fees. And so FAR works with a whole bunch of different providers in figuring out payment plans and really trying to make it work for them. And so we're putting out this offer to the managing entities also, that if we take away the exemption, FAR would waive the bed fees on this.
Okay, any comments? Questions? Okay, good, easy. Now we're going to go to something we're not going to discuss today because it's not ready for discussion. But, oh, I'm sorry, Uta, you raised your hand.
Yes. Hi, sorry, I couldn't find my little raise the hand thing. Just a quick question on bed fees. Can you just explain that a little bit more? Is that all the fees that are associated with certification?
So the fees associated with certification, and I should have clarified this, are the administrative fee and bed fees. And yes, we would agree to waive both.
Okay, thank you.
Yep.
Okay, thank you. We're going to go to 6B. And again, this is a lot to chew on in the last few days in getting this information. As many of you know, we were talking about for several meetings, utilizing the study, but in any case, creating a legislative scheme to replace 419-001, which is not only out of date since it was enacted in 1989, it doesn't include recovery residences in 419, and it also is patently violates federal law by requiring 1,000-foot or 1,200-foot buffer between homes, community homes that house disabled adults or children, and also has a prohibition of setting a home up within 500 feet of a residential area. So it really doesn't even address residential areas that are not multi-unit or multifamily, but single-family residential areas. So it's got to go one way or another. Now, I started off by just throwing it out there with the idea that the major things to accomplish are, number one, universal certification, if you want to take advantage of, say, a 660-foot buffer or distance requirement. You know, it's certainly better than what we've got, which is a lot more. You know, it doesn't hit everything. It probably it does need a lot of work. And then in the interim, Dan Lauber, who is on the meeting, he's just tuned in. He sent me a very well thought out, but you know, something that needs a lot of TLC because it's not in legislative speak, and we got to tighten it up. But a concept where you're going to have a permitted use, and also something that takes into consideration recovery communities, you know, we need to discuss this in depth. It's just not time to discuss it right now. I know that there's a minority of people out there who I respect and who have been in the business, who believe that any distance separation is discrimination, flat out. We're going to have that discussion. Everybody's going to have a chance to chime in. You know, I will give you my opinion that anything that changes 419-001 to say that there's no siting requirements or distances is dead on arrival. We've positively passed legislation in 7 of the 8 last legislative sessions, partly because we've always compromised and moved the space forward, the recovery space forward in increments. So I hope everybody we can have a robust conversation. December 13th, put it in your calendars. Mary Ann has been out for a couple of days, so I haven't confirmed with her. But seems like that we can't do it the week of Christmas. And I'm out the week before. So that looks like Friday the 13th, which is a perfect day to spend 2 or 3 hours discussing zoning and site selection. So I will be sending out a lined version of, now this is my version, which we're going to probably scrap. I don't think this really needs much more work. But the second version, if you put that up there, you all got it. It's Dan's version. And I just put it in a line format without doing any editing. It's item 6B. That probably is it. Nope, that's mine. Should be 6A. Okay. Anyway, don't want to belabor this, but we'll have that discussion. I also want to, since I'll be sending out a line version, once I do a few edits on there to make it a little more shipshape within the next week or so, you'll be getting line version. And you want to do a red line on it and send it back to me, that's fine. But we will have a discussion. I invite having discussion with anybody who wants to talk to me. You are not a sunshine group, but I'm treating you like one. You're a think tank more than anything else. Everybody, who's on this think tank task force. But just in an abundance of caution, I lead this thing, so there's no sunshine issue with me. So anybody who wants to call me, anybody who wants to discuss any particular section, send me emails. Do, like I said, a red line on this. I'll look at it and we can discuss. Anybody have any comments of Jeff? You raised your hand, so let's start with you.
I just I know from dealing with this issue for so many years on 419 that there are a lot of other trade groups and anything from ALFs to, everyone's kind of like has a stake in this. And I don't know if we need to try to get ahead of them or ahead of this with them with this legislation, or just goes through the normal process where we all do what we do and then it works out legislatively. I just don't want to see their lobbyists and people come and hit it without really understanding what we're trying to do.
That's a great point. That's a great point, Jeff. And I will tell you this. I'd go out and play the lottery if anything dealing with 419 passes this legislative session. Because I'll say, we're the luckiest group in the whole wide world that we got something. This is going to take a couple of years.
Yeah.
And I think we're going to have, you are correct. We're going to have to get all the other nonprofit agencies, government agencies that are going to, that's not it.
Well, and I'll just, at a minimum, I can say is, and we'll leave it, is if you remind me, when we were, and Dan, you were there too, Lauer, when we were revising the county's ordinances, they have something called LDRAB, the Land Development LDR Regulatory Advisory Board, that a bunch of people were invited to. We could probably get the list and the names of all the people that came there because there were a lot of trade groups there. And so I'm saying I'll give those to you. And then if you or whomever wants to reach out to them, if we want to do that now or later, I don't know. I'm just saying we already have some names that we could probably start with.
That's a great, again, that's a good point on a good point. Send me anybody you think should be involved in the discussion on the 13th, and we'll send them out an invite with a Zoom link. They don't have to be on this task force to be able to contribute. That's going to be a free format. It'd be nice to have a representative rather than 6 people from a board who all want to speak, because it's going to be, it may be a full 3-hour meeting, but but yes, send anybody you think should get an invite to do this, and we can send out the proposed language And there'll be changes in the proposed language as it's only going to be a couple of weeks, but it's the best we can do. And then we'll talk about it again in January. Legislative session doesn't start till March. We probably are going to get something filed, I hope, sooner than that. And it's an ongoing process. So thanks, Jeff. That's great idea. Terrell, you had your hand up next, and then Dan. Terrell, you got to unmute yourself.
I am unmuted. Can you hear me?
Okay, yeah, I can hear you now.
Okay, what time on December 13th?
It would be 1 o'clock.
Okay, just wanted to make sure. Thank you.
Okay, Dan.
I just want to say, as always, Jeff, I agree with Jeff that this needs to be a broad-based coalition in support of the legislation, which I think is very likely to happen with organizations that represent people with other disabilities, because it will basically cut in half the current spacing distance, eliminate all these absurd provisions that, for example, disallow the homes for 7 or more people from within 500 feet of a single family district, and all the other defects in the state law that really run afoul of the Fair Housing Act. So it really opens up a whole lot more housing opportunities to community residences of all types than what currently exists in, I suspect, most of the state of Florida. But I also want to emphasize this is what I put together as a first draft. It needs massaging, it needs proofing, it needs refinement, and I really look forward to hearing via Al what people may have for us to make this really tight. One thing I'm concerned about, and if anyone can come up with some language, I'd appreciate it, is with the exceptions to the spacing distance. As I pointed out in the report, we want to really make it clear in the state legislation that the spacing distance is not concrete, that if you want to locate within a spacing distance and you're not going to interfere with normalization, community integration at the closest existing community residence, we want to give some guidance to get the cities to take into account the actual on-the-ground pedestrian distance between the homes, as well as the nature of the populations, because that makes a monster difference into whether or not a home should be allowed within the spacing distance. And in certain situations where you're dealing with different populations and the on-the-ground distance is much greater, there's 1,000 feet or 1,200 feet, and they're not likely to interact with each other from the two homes, the special permit or whatever method the city or county wants to use should be granted. I'm trying to figure out how we fit that into the state legislation so we take away ambiguity on this, because this is where we've had a problem, as Jeff can attest, with some local officials thinking that the spacing distance was intended to be absolutely concrete and totally inflexible.
There are many Florida statutes that lay out provisions to assist in terms of duties and responsibilities. Even licensing, if you're a licensed provider, there are certain specific thresholds that you need to meet, the things that you need to do, things that you can't do. We can certainly talk about and develop a reasonable accommodation guideline, and that can be put into statute. That's not an issue, but we have to come up with what it is. And that's going to take some conversation, and going to take the expertise of people like you and Jeff and Terrell to be able to put it in language that you can't drive a truck through loopholes, and et cetera, et cetera.
Yeah, the guidelines are in the study. There's several pages devoted to that particular question. And I wonder if it's possible to do a legislative reference that, I assume the study will be part of the legislative history.
Now, you can't,
I have no idea.
you can't do that, I don't think, unless somebody can show me where you can. But what you can do is you can take the bullet points from what it is and put it in statute. just take the bullet points, and if there are 9 things, you put A through, whatever letter 9 is.
Well, we could put it in, the deciding body shall consider A, B, C, and
Right.
D. Yeah,
Yeah,
okay.
it's necessary to in considering reasonable accommodation, a local government entity shall. And then consider this, consider that, blah, 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 to put it into, and it would be good to have no confusion over the difference between permitted use and reasonable accommodation, because reasonable accommodation is universal no matter what, no matter where it is. Okay, any other comments or questions? I'm both excited and full of trepidation because as my new boss, Alexia Cox, knows, there's a lot of other things I need to do that are my core function here at the office. So, I'll be burning the midnight oil on some of this stuff. So go easy on me, okay? Anyhow, any other I promised you, it's 2:40. We're getting out of here. And anybody have any comments for the good and welfare? Any comments from the community? Good meeting, everybody. Thank you so much. And we'll see you on December 13th.